Good morning and welcome, everyone. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices. Today is January 12th, 2022, and I'm pleased to call today's ACIP meeting to order. Today, we will not be talking about COVID vaccines, and instead we'll focus on reviewing data for several other important vaccines. I will turn it over to Dr. Melinda Wharton to share today's announcements.
Good morning. Thank you, Dr. Lee. Next slide, please. Welcome to the January 12th virtual ACIP meeting. Copies of the slides being presented at today's meeting are available on the ACIP website or will be there soon if they're not already up. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those who are listening on the Zoom line. Please mute your lines at all times unless you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the raise hand function in Zoom to virtually raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from ex officio members and liaison representatives. Please disable your video other than a profile picture if you have one up. ACIP voting members, we will ask you to turn on your video during the votes. Next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body. Engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we will be holding one oral public comment period at approximately 3:10 p.m. Eastern Standard Time. To create a fair and more efficient process for requesting to make an oral comment, people interested in making an oral comment are requested to submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2021-0132. Information on the written public comment process, including as well as information on how to make a comment, can be found on the ACIP meeting website. Next. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines of that company. At the beginning of each meeting, ACI members state any conflicts of interest. Next. And with that, I will turn the podium back over to Dr. Lee.
Thank you, Dr. Wharton. We will start with roll call, and for the ACIP members, I'll ask that you state your name, your affiliation, and whether you have any conflicts of interest. This morning, we will start with Ms. Bata.
Good morning, I'm Lynn Bata. I am a clinical consultant with the immunization program at the Minnesota Department of Health, and I have no conflict.
Thank you. Next, we'll move to Dr. Long.
Good morning, this is Sarah Long. I'm a professor of pediatrics at Drexel University College of Medicine and a pediatric infectious disease doctor in Philadelphia. I have no conflict to disclose.
Thank you, Dr. Long. Next, we'll move to Dr. Alt.
Morning, my name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Hospital in Kansas City, Kansas, and I have no conflict.
Thank you. Next, we'll move to Dr. Bell.
Good morning. I'm Beth Bell. I'm a clinical professor in the Department of Global Health at the University of Washington, and I have no conflicts.
Thank you. Dr. Chen?
Wilbur Chen, Professor of Medicine, Adult Infectious Disease Physician. My employing institution, the University of Maryland, has a grant from Emergent Biosolutions that supports work I do on developing a Shigella vaccine. This constitutes a clear conflict of interest in the cholera vaccine discussion, or the cholera vaccine, I should say, which I also mentioned was invented and developed at my center, the Center for Vaccine Development and Global Health. So I'll be recusing myself from voting on decisions for the cholera vaccine, which I believe are planned for February.
Thank you, Dr. Chen. Next, Dr. Sineas.
Dr. Sybil Sineas. I am an internist and pediatrician, associate professor of medicine and pediatrics at Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly?
Good morning. Matt Daly. I'm a senior investigator at Kaiser Permanente, Colorado, and an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts.
Thank you. Dr. Lair? Let's move to Dr. Cotton.
Good morning, Dr. Camille Cotton. I am the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts.
Thank you. Dr. Paling.
Good morning. This is Kathy Paling. I am a professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist, and I have no conflicts. Thank you.
Ms. McNally.
Good morning. Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Sanchez.
Pablo Sanchez, professor of pediatrics at the Ohio State University School of Medicine, College of Medicine, and I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's Hospital, and I have no conflict. Thank you.
Thank you, Dr. Sanchez. Dr. Talbot.
Good morning. I'm Kip Talbot. I'm an associate professor of medicine and health policy at Vanderbilt University Medical Center, and I'm an adult infectious disease physician.
Thank you. I am scanning the list. Dr. Lair.
Dr. Jamie Lair. I'm a private family physician at Cuda Family Medicine in Ithaca, New York, and I have no conflicts.
Thank you. Is Dr. Brooks available?
Oliver Brooks here. Good morning. Chief Medical Officer of Watts Healthcare Corporation, Los Angeles. I have no conflicts.
Thank you, Dr. Brooks. And I'm Grace Lee. I'm at Stanford University School of Medicine, Professor of Pediatrics, Associate Chief Medical Officer for Stanford Children's Health, and I have no conflicts. And with that, we will move on to our ex officio and liaisons. First, we'll start with Centers for Disease Control and Prevention.
Good morning, Sam Posner, NCIRD.
Thank you. Centers for Medicare and Medicaid Services.
Good morning, this is Mary Beth Hans for CMS.
Thank you. Good morning. Food and Drug Administration.
Hi, good morning. I joined just in time. Doran Fink, U.S. Food and Drug Administration, Office of Vaccine.
Thank you, Dr. Fink. Next, we'll move to Health Resources and Services Administration.
Good morning. This is Mary Rubin for Division of Injury Compensation Programs, HRSA.
Thank you, Dr. Rubin. Indian Health Service.
Good morning. This is Dr. Matthew Clark with the Indian Health Service.
Thank you, Dr. Clark. National Institutes of Health.
Good morning. John Weigel, National Institute of Allergy and Infectious Disease, NIH.
Thanks, Dr. Weigel. Office of Infectious Disease and HIV/AIDS Policy.
Good morning. This is David Kim representing OIDP in the Office of the Assistant Secretary for Health.
Thank you. We'll move on to our liaison representatives. And as a reminder, you can just state if you are present for your organization and your first and last name. American Academy of Family Physicians.
Pamela Rockwell, AAFP, present.
Thank you. American Academy of Pediatrics.
Good morning, Bonnie Maldonado, Chair, Committee on Infectious Disease, American Academy of Pediatrics.
Thank you. American Academy of Pediatrics Red Book.
David Kimberlin, editor of the AAP Red Book.
Thank you. American Academy of Physician Assistants.
Marie Michelle Leger, present.
Thank you. American College of Health Association.
Erin McMullen and Dr. Tavi Chai for the American College Health Association.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
Linda Eckert, present.
Thank you. American College of Physicians.
Jason Goldman, present.
Thank you. American Geriatric Society.
Ken Schmader, present for AGS.
Thank you. American Health Insurance Plans. Okay, we'll move on to American Immunization Registry Association.
Good morning, Rebecca Coyle is here representing ERA.
Good morning. For those of us on the West Coast, American Medical Association.
Sandra Freihofer, General Internal Medicine physician in Atlanta, Adjunct Associate Professor of Medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association. Come back. American Osteopathic Association.
Stan Grog, good morning, and I'm present.
Morning. American Pharmacists Association.
Good morning. This is Michael Hogue, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, Immunization Director for the North Dakota Department of Health, representing AIM.
Thank you. Association for Prevention, Teaching, and Research.
Rick Zimmerman at the University of Pittsburgh, representing APTR.
Thank you. Association of State and Territorial Health Officials. Welcome back. Biotechnology Innovation Organization.
Good morning. Phyllis Arthur, representing Bio.
Thank you. Council of State and Territorial Epidemiologists. I believe they might be calling in late. We'll move on to Canadian National Advisory Committee on Immunization.
Matthew Tunis for NACI.
Thank you. Infectious Disease Society of America.
Carol Baker, good morning.
Morning, Dr. Baker. International Society for Travel Medicine.
Elizabeth Barnett here for ISTM.
Thank you. National Association of County and City Health Officials. Thanks. I think that was Dr. Zahn's voice. National Association of Pediatric Nurse Practitioners.
Good morning, Patsy Stinchfield for NAPNAP.
Thank you. National Foundation for Infectious Disease. Come back. National Medical Association.
Hi, Virginia Kane, Chair of the Infectious Disease Section for the National Medical Association and Associate Professor, Division of Infectious Diseases, Indiana University School of Medicine.
Thank you, Dr. Kane. Pediatric Infectious Diseases Society.
Sean O'Leary, representing PIDS.
Thank you, Dr. O'Leary.
Thanks.
Pharmaceutical Research and Manufacturers of America.
Good morning, Corey Robertson, present.
Good morning. Society for Adolescent Health and Medicine.
Good morning, it's Amy Middleman representing SAM.
Thank you. Society for Healthcare Epidemiology of America.
Good morning, Dr. Marcy Dries, Chief Infection Prevention Officer at Christiana Care, representing SHEA.
Thank you. And if any individuals have joined from any of the liaison organizations and would like to announce themselves now, please go ahead.
Hi, this is Marla Dalton, representing National Foundation for Infectious Diseases, and Bill Schaffner will be joining later.
Thank you. Any other organizations? Okay, terrific. I believe we do not have any opening remarks that we need to add for today, so we will plan to move on to the first session of the morning. During today's meeting, as a reminder, Dr. Wharton mentioned, I will invite individuals to contribute to the discussion. Please raise your hands electronically, and I'll call on ACIP members first, followed by our ex officio members and liaisons. And I would like to turn it over to Dr. Pablo Sanchez, who is chair of the Cholera Vaccines Work Group. He will provide an introduction and overview of today's session. So Dr. Sanchez.
Thank you, Grace. Next slide. So first of all, I would like to thank the members of the Cholera Vaccine Work Group and my co-ACIP member, Matt Daly, as well as ex officio officers and ACIP liaisons, technical advisors, CDC contributors, and great consultants who've just helped us tremendously, but also specific shout out to the CDC lead, Jen Collins, who's just done, as you'll see, she's done a spectacular job of leading our group forward. Thank you. And next slide. So the policy topic under consideration by our work group is should ACIP recommend the cholera vaccine for children and adolescents aged 2 to 17 years traveling to an area with active cholera transmission. Next slide. So we'll hear today from the Vaxchora vaccine, the pediatric dose development from James McCarty from Emergent Biosolutions. And then Jen Collins will present the evidence to recommendations for the cholera vaccine among children and adolescents aged 2 to 17 years. Thank you. I believe that's the last slide.
Thank you, Dr. Sanchez. We'll turn it over to Dr. James McCarty from Emergent Biosolutions, who will present on the development of pediatric cholera vaccines. Dr. McCarty.
Thank you. And I'd like to very briefly turn over the speaker to Dr. Mark Schneider, who's going to give a brief introduction. Mark?
Thanks, Dr. McCarty. Hi, Dr. Mark Schneider. I'm a Senior Director here at Emergent Biosolutions for Global Medical Affairs and Infectious Disease. And I want to thank you all very much for the time and opportunity this morning to speak on behalf of Emergent and more specifically Vaxchora. I'm joined by Dr. Paul Duffin and Dr. Lisa Bedell, along with Dr. McCarty, who will walk you through the data to support the supplemental filing early this year for the addition of a sweetener to the label for Vaxchora. As you know, and as a reminder, it is a vaccine indicated for active immunization against the disease caused by Vibrio cholera serogroup 01 and is approved for use in persons 2 through 64 years of age traveling to cholera-affected areas. We anticipate filing again early this year with a verdict by the FDA in Q3 or Q4 of 2022. And again, product will be available back on the market May 1st for prescribing. So with that, thanks very much, and I'll turn it back over to Dr. McCarty.
Thank you very much, Mark. Good day. My name is James McCarty, and I'd like to thank you for the opportunity to speak here. Today, I will provide a brief overview of recent studies addressing the pediatric dosing volume and palatability of the live attenuated oral cholera vaccine, Vaxchora. Next slide, please. Vaxchora is composed of 2 packets, also called sachets, that are reconstituted in bottled water prior to administration. The first of the 2 packets contains a buffer powder, which neutralizes stomach acid and facilitates the passage of vaccine into the intestines. The second packet contains the active component, which is composed of 2 grams of the lyophilized Vibrio cholerae CVD 103 HGR vaccine strain. Next slide, please. Vaxchora has been evaluated in a phase 1 study and several randomized, double-blind, placebo-controlled phase 3 and 4 trials in over 4,000 subjects 2 to 64 years of age, as summarized here. Objectives have included safety, immunogenicity, shedding, and clinical efficacy. In the phase 3 challenge study, seroconversion was noted in most subjects by 7 days after immunization, and Vaxchora demonstrated 90.3% efficacy at 10 days and 79.5% efficacy at 3 months versus placebo against challenge with a virulent strain of Vibrio cholerae. A second phase 3 study documented lot-to-lot consistency, and a third phase 3 study demonstrated a similar immune response in older adults compared with younger adults. A phase 4 study demonstrated that Vaxchora is well tolerated and safe in children ages 2 to 17 years, with seroconversion occurring in 98.5% of subjects by 10 days post-vaccination, a seroconversion rate that is non-inferior to that seen in adults. Next slide, please. The pediatric dosage form development plan was designed to adapt the vaccine to children and to cover the needs of all children from birth to adolescence. The primary goals of the product development studies that we are presenting today were to use the existing approved Vaxchora formulation as described in the previous slides, and to adapt the vaccine to children 2 to 6 years of age by reducing the administration volume and masking the taste. The methods used were to reduce the administration volume from 100 to 50 milliliters and to investigate the compatibility of different flavoring options and taste masking strategies with Vaxchora. Next slide, please. The first step in the development of the Vaxchora pediatric dose was to reduce the volume. Several reconstitution methods were tested, including simply adding the buffer and active component to 50 milliliters of water instead of the 100 milliliters prescribed for the approved vaccine in adults. As noted on the left in row 2, reconstituting the full buffer into 50 milliliters of water resulted in a pH of 7.16, which is above the release specification. As noted on the right in row 2, reconstituting the full buffer and vaccine components directly into 50 milliliters of water resulted in a slight drop in vaccine potency. As noted on the left in row 3, an alternative was to reconstitute the buffer in 100 milliliters of water, followed by discarding half and reconstituting the entire active component in the remaining 50 milliliters of buffered water. In this case, the buffering capacity was below specification, since half of the reconstituted buffer was discarded. As seen on the right, in the third row, when using this method, the Vaxchora solution remained within the potency specification for at least 15 minutes. The reduction in buffering capacity was deemed acceptable because children have a lower gastric volume and higher gastric pH than adults. This is the dose method that was used with the 2 to 6-year-old group in the pediatric trial, which resulted in high seroconversion rates and which was approved by the FDA for use in children. Next slide. It was concluded from these results that the buffer should be kept at the same concentration as the adult formulation and that Vaxchora is stable when reconstituted in this way in 50 milliliters of buffered water. Next slide, please. This slide shows the 50 milliliter reconstitution method that was used in children ages 2 to 6 in the pediatric trial. The buffer component was added to 100 milliliters of water and stirred. 50 milliliters of the buffered water were then discarded. Then the entire active component sachet was added to the 50 milliliters of buffered water and stirred. At this point, there was an option to add a sweetener, in this case, stevia. The sweetener was stirred into the reconstituted vaccine, and then the vaccine was consumed within 15 minutes. Next slide, please. Next step in the development of Vaxchora pediatric dose, the next step in the development of the Vaxchora pediatric dose was to investigate the compatibility of different flavoring options and taste masking strategies. Over-the-counter flavoring agents such as FlavorX or Yummy Meds contain propylene glycol, which has been shown to be bactericidal. Data not shown here documented Vaxchora colony counts well below the lower limits of specification when FlavorX was added to the vaccine mixture. During the pediatric study, only Pure Via stevia sweetener was used to flavor the vaccine. Therefore, a more thorough study of the compatibility of Vaxchora with sucrose in different brands of stevia was performed. Stevia is much sweeter than sugar, so fillers are used to add bulk, and the stevia itself generally accounts for less than 5% of the sweeteners by weight. Our strategy in the lab was to choose stevia brands that are available worldwide and contain the most commonly used fillers. An online search showed that the stevia market is consolidated and dominated by just a few players, including Cargill, the makers of Truvia, and Tate & Lyle, the makers of Splenda. The most commonly used fillers of popular brands are inulin, erythritol, maltodextrin, and dextrose. Next slide, please. Representative brands of stevia powder or stevia crystals were chosen to include popular brands and the most common filler ingredients. 1 gram of stevia, which is equivalent to 1 packet that you would buy in the store, or 1 or 4 grams of sucrose, were added to 50 milliliters of reconstituted Vaxchora, and the potency was tested after 15 minutes. As can be seen on the right, Vaxchora potency was maintained in the presence of sucrose in all brands of stevia tested. Next slide, please. In conclusion, Vaxchora is well tolerated and likely effective in children ages 2 to 17 years. Vaxchora is compatible with both sucrose, up to 4 grams, and stevia sweeteners in a reconstitution volume of 50 milliliters. It is compatible with stevia brands available around the world, including their common fillers. Vaxchora should not be used with medicine flavorings such as Flavor-X or Yummy Meds due to the presence of propylene glycol. Thank you for your time today. I'll be glad to answer any questions you may have.
Thank you, Dr. McCarty, and thank you for trying to make these vaccines so palatable for young kids. This presentation is now open for questions. I see Dr. Hoag's hand raised. Dr. Hoag.
Thank you so much for this presentation. As a pharmacist, we're always quite interested in how we can help our pediatric patients to take medicines and, of course, vaccines. And so flavoring is very, very important. I just want to be very clear here. So as the product comes to market for pediatric use, the labeling will be very clear. You gave a picture, I believe, of the reconstitution instructions. You didn't mention at all whether or not sweetener could be added to the adult dose. It would seem logical that that would be okay to do that. You focused on pediatric only, but if you had an adult patient who had certain taste aversions, would it be acceptable to add the sweetener to the adult product as well? Any concerns there?
Well, I'm not exactly sure what was submitted in terms of the label regarding just the pediatric form or the adult form. So with that caveat, I don't see any reason why there would be any issues when adding stevia or sucrose to the adult 100 milliliter mixture based on the laboratory data that we've generated so far.
And just to be clear, the manufacturer does not intend to supply the product, but the sweetener, what you're implying is that the pharmacist or the nurse or the physician would actually use an off-the-shelf packet of stevia or Truvia or some similar sweetener? Or are you saying that the manufacturer is going to supply a sweetener with the product as it's provided to vaccine providers?
There are not plans at this time for the manufacturer to provide a sweetener with the product.
Thank you. Dr. Paling?
Okay, thank you for this great presentation. So what I'm thinking about is that when parents present to a travel clinic, they will sometimes have multiple children in this age group. When we get to the product distribution, you can imagine that you would take 100 milliliters of water, add the buffer, and instead of discarding it, you have 2 children. So then you could use 50 milliliters for each and put the vaccine in there. Is that going to be considered to enhance efficiency? Thank you.
Well, each container of the vaccine has 2 sachets. One is the sachet that contains the buffer, and the other is the sachet that contains the vaccine. So you would still need to use 2 packages of Vaxchora in order to immunize 2 children. Now, if you were to take that 100 milliliters and discard 50 into an adjacent container and then have 2 equal 50 milliliter containers of buffer solution, I don't see any reason why you couldn't then come along and add 2 complete and separate vaccine sachets to those containers.
Okay, great. Thank you.
Thank you. Are there any other questions? Dr. Kim.
Thank you, Dr. Lee. Just a simple question on the possibility of how to roll out the recommendations down the line. The Vaxchora is we're talking about recommending it for children ages 2 through 17 years, and the child and adolescent immunization schedule goes through age 18 years, and adult immunization schedule begins at age 19. So there's that age 18 that is not included for children and adolescents. And I'm simply asking this question as a way to simplify the recommendations for practitioners when they look at the schedule. And I wonder, actually, I understand that the Vaxchora will not be specifically added in the pediatric or adult immunization schedule per se. But what is the what does data say about 18-year-olds? Are they similar to the 16 and 17-year-olds?
The same product was used in the adult studies that included subjects from 18 years of age and above. That was used in the adolescents. So the data consistently support the safety and immunogenicity in 16, 17, 18, 19-year-old subjects. I think the cutoff in terms of your verbiage, I think that would be up to ACIP, how you want to word that. They're supported.
Thanks, Jim. This is Mark Schneider from Emergent. I would just add that, yes, indeed, and as indicated in the label, it is indicated for persons 2 through 64. So, again, at ACIP's discretion in terms of the language.
Thank you.
Thank you. Dr. Daly.
Yeah, thanks so much. I just wonder if I think I understood, but so to give you an opportunity to clarify. So the amendment submitted to the FDA would just amend the package insert to specify which type of sweeteners could be used. Is that the sort of extent of the current amendment with the FDA? Over.
Yes, that is correct.
That is correct.
We're also addressing the type of water.
Thank you. I'm just going to ask perhaps a question that might be obvious to our group members, but is not obvious to me. The intent to do the reduced volume for the 2 to 6 years of age, I'm just thinking about how to minimize administration errors in this case for high volume clinics. Is it because that you're trying to stick with the existing sort of manufacturing and formulation of the vaccine for the older kids and then just reducing the volume, or would there ever be an intent to create a 2 to 6 year old specific set of sachets?
Yeah, there's not at this time. At this time, the plan is to stick with one type of manufacturing process.
That's right. From a streamlining the manufacturing perspective, that is not in the forecast.
Thank you very much. Are there any additional questions? All right, thank you. Thank you, Dr. McCarty and Dr. Schneider. We'll move on to Dr. Jennifer Collins from CDC, who will present on the evidence to recommendations framework for children 2 to 17 years old. Dr. Collins.
Good morning, and thank you for having me. Next slide. Regarding the background of the work group, in June 2016, ACIP recommended the cholera vaccine, CVD-103-HTR, trade name Vaxchora, for adult travelers aged 18 to 64 years from the United States to an area with active cholera transmission. This is the only cholera vaccine licensed for use in the United States. In October 2020, the current ACIP cholera vaccine work group formed. In December 2020, FDA extended the approved usage of Vaxchora to include children and adolescents aged 2 through 17 years. And in February 2022, the work group presented background information and the manufacturer presented pediatric clinical trial data. Next slide. As Dr. Sanchez noted, the current policy question under consideration is, should ACIP recommend CVD-103-HTR for children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission? Next slide. The components of the PICO question are shown here. The population is children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission. The intervention is lyophilized CVD-103-HTR, a single dose, oral, live attenuated bacterial vaccine. The comparison is no cholera vaccine. The work group identified the 4 outcomes shown here as the most important for the PICO question: cholera diarrhea, moderate or severe, cholera diarrhea of any severity, serious adverse events, and non-serious adverse events. Next slide. The extra recommendation domains and relevant questions are shown here, and I will review each of these in detail in the coming slides. Next slide. We will begin with the ETR domain public health problem. Next slide. The work group considered the main question: is cholera among children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission a public health problem? I will discuss the sub-questions shown here on the upcoming slides. Next slide. The first 2 sub-questions are the consequences of cholera serious, and is cholera urgent? Infection with toxigenic Vibrio cholerae L1 can cause a range of symptoms. Although most infections are asymptomatic, mild or moderate, up to 10% of infections manifest as cholera gravis, the most severe form of cholera. Cholera gravis is rapidly fatal if untreated. Fluid management is the primary focus of treatment, and rehydration can reduce the fatality rate to less than 1%. However, patients with cholera gravis may require up to 350 milliliters per kilogram of fluids within the first 24 hours of illness. Next slide. The next sub-question is, are many travelers aged 2 through 17 years from the United States affected by cholera? Most international travelers from the United States do not get cholera because they do not visit areas with active cholera transmission, and they have good access to safe food and water. During 2012 through 2018, 64 cholera cases were reported in the United States. 5 patients, or 8%, were aged 2 through 17 years. 2 deaths occurred in adults. 88% of cases were travel associated. However, national cholera case counts underestimate the true burden of illness, given limitations inherent in surveillance for laboratory confirmed infections. Next slide. The last 2 sub-questions are, is cholera related to emerging diseases, antimicrobial resistance or epidemic potential, and are disadvantaged groups or populations disproportionately or differentially affected by cholera? Antibiotic resistance can occur among the bacteria causing cholera. However, fluids and not antibiotics are the mainstay of treatment. Antibiotics are adjunctive therapy in moderate to severe illness. An estimated 1.3 to 4 million cholera cases and 21,000 to 143,000 cholera deaths occur worldwide each year. Cholera epidemics are associated with unsafe water and inadequate sanitation. Secondary cases are rare if sanitation is adequate. Therefore, a U.S. outbreak from a returning traveler is unlikely. Next slide. The work group deliberated whether cholera is a public health problem among children and adolescents aged 2 through 17 years old traveling to an area with active cholera transmission. Work group members agreed that cholera is a public health problem for local populations in endemic settings due to unsafe drinking water and inadequate sanitation. However, for travelers from the United States, work group members felt that even within cholera endemic areas, the risk for travelers varies by travel destination, travel activities such as tourism versus visiting friends and relatives, and access to safe food, water, and sanitation. Apart from the public health question, members noted cholera may pose a meaningful individual risk for ill travelers with inadequate or delayed access to fluid replacement therapy, even in instances when the risk of secondary transmission is low. Finally, cholera may become a bigger problem for travelers in the future, and the work group agreed having a supply of cholera vaccine for U.S. travelers is important. Next slide. For the public health problem domain, most work group members felt our determination should be probably yes, though some felt it should be probably no or varies. The final work group consensus was probably yes. Next slide. Now I will review benefits and harms. Next slide. We considered How substantial are the desirable anticipated effects overall and for each main outcome for which there is a desirable effect? And how substantial are the undesirable anticipated effects overall and for each main outcome for which there is an undesirable effect? Next slide. We also considered, do the desirable effects outweigh the undesirable effects? And what is the overall certainty of this evidence for the critical outcome? Next slide. The work group categorized the PICO outcomes as benefits and harms. Prevention of cholera diarrhea, moderate or severe, and prevention of cholera diarrhea, any severity, were rated as critical benefits. For harms, serious adverse events was rated as critical, and non-serious adverse events was rated as important. Next slide. We conducted a systematic review to identify evidence on use of CVD 103-HTR among children and adolescents aged 2 through 17 years. We identified published articles using the databases and search terms listed here. Studies were included if they provided data on the current formulation and dose of the vaccine, involved human subjects aged 2 through 17 years, reported primary data relevant to the efficacy and safety outcomes, and were conducted in cholera non-endemic settings. Titles and abstracts were screened by 2 reviewers. Next slide. Overall, 571 records were identified and screened, and 3 studies were included in the grade review of the evidence. Next slide. These 3 articles identified summarize a phase 4 randomized double-blind placebo-controlled trial among children and adolescents aged 2 through 17 years. Results of the clinical trial were presented to ACIP by the manufacturer in February of 2021. In summary, the study setting was 7 U.S. sites from July 2017 through September 2019. The sponsor enrolled healthy children and adolescents aged 2 through 17 years, divided into the 3 age cohorts shown. Participants were randomized in a 6-to-1 ratio to receive the vaccine at a 1/10⁹ colony-forming unit dose or physiologic saline placebo. Participants or parents could request an optional sweetener for palatability, which was pure via brand stevia, and at least 92% of participants in each study arm chose this. The relevant outcomes address safety and immunogenicity. Next slide. Regarding outcomes 1 and 2, cholera diarrhea moderate to severe and cholera diarrhea any severity, no pediatric studies directly assessed vaccine effectiveness. Assessment of these outcomes was based on immunobridging to adults in whom efficacy has been demonstrated. In a separate study, wild-type Vibrio cholerae 01 was administered to participants ages 18 through 45 years following vaccine or placebo. The correlation coefficient between cumulative diarrhea in liters and fold increase in serum vibricidal antibody was negative 0.75 at 10 days and negative 0.69 at 3 months. Separately, in endemic settings, fold increases in serum vibricidal antibodies correlate with protection in both adults and children. Next slide. The grade evidence table for cholera diarrhea, moderate to severe, and cholera diarrhea, any severity, is shown here. 2 randomized control trials were included, and the evidence certainty began as type 1. The work group downgraded the evidence for serious indirectness because efficacy is inferred from immunobridging. The pooled effect estimates demonstrate that seroconversion was more likely among vaccine recipients than among placebo recipients. The final certainty was type 2 or moderate. Next slide. The grade evidence table for serious adverse events is shown here. 2 randomized control trials were again included, and the evidence certainty began as type 1. No serious adverse events were attributed to the vaccine in either study. The work group downgraded the evidence for very serious imprecision based on the small sample size to assess rare serious adverse events, the small number of events, and the wide 95% confidence interval that crosses the line of no effect. The final certainty was type 3 or low. Next slide. The grade evidence table for non-serious adverse events is shown here. This was assessed by any solicited adverse event on study day 1 through 8. Again, 2 randomized control trials were included, and the evidence certainty began as type 1. The work group downgraded the evidence for very serious imprecision based on the wide confidence interval that crosses the line of no effect. The final certainty was type 3 or low. Next slide. A summary of the grade evidence is shown here. For the critical benefits of cholera diarrhea, CVD-103-HTR effectively induces serum vibrio-sidal antibody seroconversion, an imperfect correlate of protection against cholera. The final evidence type was type 2 or moderate. For the critical harm serious adverse events, none were judged to be related to the vaccine, and the final evidence type was 3 or low. Finally, the frequency of non-serious adverse events was not meaningfully different among vaccine versus placebo recipients, and the final evidence type was 3 or low for this important outcome. Next slide. All the work group felt that the desirable anticipated effects were moderate and that the undesirable anticipated effects were small. Next slide. The work group felt the balance between desirable and undesirable effects favors the intervention CVD-103-HTR. The overall certainty of evidence for this critical outcome was low. Next slide. Now I will discuss the Etr Domain Values. Next slide. The work group used to assess values are: does the target population feel the desirable effects are large relative to the undesirable effects? And is there important uncertainty about or variability in how patients value the outcomes? Next slide. For values, no research evidence was identified. The work group noted that cholera vaccines are optional and individuals can decide whether to get it based on their values. Next slide. The work group determination for values was don't know. Next slide. Now I will discuss acceptability. Next slide. To assess acceptability, the work group considered whether the intervention is acceptable to key stakeholders based on the questions shown here. Next slide. For acceptability, no research evidence was identified. However, the work group noted that travel medicine providers and medical associations, such as the Infectious Diseases Society of America, the American Academy of Pediatrics, and the Pediatric Infectious Diseases Society, are likely to find it acceptable to administer CVD-103-HTR to children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission. Next slide. The work group determination for acceptability was yes. Next slide. Now to resource use. Next slide. The primary question the work group used to assess resource use was: is CVD-103-HTR among children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission a reasonable and efficient allocation of resources? This includes sub-questions about the cost effectiveness of vaccination. Next slide. For resource use, no research evidence was identified. A cost analysis was not conducted given the optional nature of the vaccine among travelers. Next slide. For research use, the work group determination was don't know. Next slide. Now I will discuss equity. Next slide. The main question used to assess equity was: what would be the impact on health equity of the vaccine among children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission? This includes the sub-questions shown here. Next slide. For equity, no research evidence was identified. However, the work group expressed concern for possible inequity, noting that underserved populations may have difficulty accessing and paying for the vaccine. Work group members noted that travelers visiting friends and relatives, or VFR travelers, in cholera endemic areas are likely at highest risk for illness, but are often uninsured. For other travel vaccines, VFR travelers are often less likely than other travelers to come to travel clinics and to receive pre-travel vaccines. Next slide. The work group determination for equity was that it varies. Next slide. Now to feasibility. Next slide. The work group considered whether CVD-103-HGR is feasible to implement among children and adolescents aged 2 through 17 years. This includes the sub-questions shown here. Next slide. Members felt it is likely feasible to administer the vaccine to children and adolescents aged 2 through 17 years in a travel clinic. The travel clinic setting is preferred because the dose preparation is more complicated than routine childhood vaccines. It requires reconstitution in bottled or purified spring water, and half the buffer is discarded for children aged less than 6 years. Additionally, it may be optimally ingested with specific sweeteners. As noted, more than 92% of trial participants used previous Stevia with their dose, and 89% of study participants consumed the complete vaccine dose. Seroconversion with partial dosing was encouraging. 69% of participants who consumed less than 50% of the dose, and all 7 patients who consumed 50% to 80% of the dose seroconverted. Finally, the recommendation may impact health equity as previously discussed. Next slide. The work group determination for feasibility was probably yes. Next slide. Again, next slide. This slide summarizes the work group determinations for each of the Etr domains, as I just discussed. Next slide. Based on the Etr framework, the work group considered the balance of consequences, ranging from undesirable effects, consequences clearly outweighing desirable consequences, to the opposite, as well as the possibility of insufficient evidence. Next slide. The work group consensus was that desirable consequences probably outweigh undesirable consequences in most settings, given that we only had indirect data to assess the desirable consequences. Next slide. Finally, the work group determined the type of recommendation based on the options shown here. Next slide. The work group consensus was that we recommend the intervention, CVD-103-HGR, for children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission. Next slide. I'd like to thank the members of the work group and other contributors to the content included in this presentation. Next slide. Thank you, and I'm happy to take any questions.
Thank you. This presentation is now open for questions and discussion. Dr. Paling.
All right, so thank you very much for this great conversation and presentation. I am trying to reconcile 2 components of what was stated and would really like your help in understanding. At one point, we were talking about how individuals would choose whether or not to get it because it's an individual benefit. In the end, we concluded that it should be recommended, and there was a choice for shared decision-making. Would you please elaborate and help me understand where the conversations were on those 2 choices? Thank you.
Sure thing, thanks. And I'll say we spent a long time deliberating sort of how we wanted to rate the specific domain of public health problem. And I think that some of that is that the ETR framework is sort of created with the lens of sort of more general vaccine policy and routine immunization in mind. And for a travel vaccine, I think we think about it a little bit differently. So overall, the work group felt that we recommend the vaccine, but also sort of acknowledged that that some people felt it maybe doesn't meet the criteria for being a public health problem in the United States, but that because it can be sort of a risk to individual travelers, and that we may not always know the status of people's risk factors that may increase their risk of cholera gravis. So that includes being blood type O, having low gastric acid, such as secondary to antibiotic therapy or partial gastrectomy, and other factors that may sort of complicate how they would tolerate having a severe cholera infection, such as heart disease and things. So you're sort of getting at sort of the conversations that we had, and I think teasing apart that we do recommend it for travelers to cholera endemic areas, even though we debated extensively whether it meets that criterion of being a public health problem. And I think that's a little bit unique to travel vaccines.
Okay, and then the second question is, what is the recommendation for adults? Is it a shared clinical decision-making, or is it a full recommendation? Thank you.
Sure, yes, it's a full recommendation, and we did our best to sort of echo the language about for adults aged 18 to 64 years, ACIP recommends it if they're traveling to areas with active cholera transmission. That's the language from the previous iteration.
Thank you. We'll move on to Ms. Bata.
Thank you. Sorry, my mouse wasn't working. I just had a little bit of a couple questions related to the domain of public health problem. And during a 6-year period, we had a certain group of individuals that weren't travel associated. Can you talk a little bit more about that? And also trying to understand, why do we think that this could be a bigger problem in the future?
I'm sorry, for the first part of your question, I'm not sure that I'm understanding what the question is.
When you reported the cholera cases that occurred in the U.S. during 2012 to 2018, there were some that were not travel associated, and can you describe, were they secondary infections from people who had traveled?
Oh, thank you. I understand now. Sure. Chris, do you mind going to slide 9 just so those numbers are up? Sure. So as noted, 64 cholera cases were reported during that 6-year period there, and 88% of those were travel associated. I don't have the exact numbers of other cases offhand, but typically in the surveillance system that is pulled from, we see that the other cases were associated with Gulf Coast seafood consumption or swimming in Gulf Coast waters, where we know that Vibrio cholerae is endemic as well. And then occasionally, just inherent in surveillance, we have cases where we don't have a particular cause identified. But I suspect that the others were associated with Gulf Coast waters.
Great, thank you. And then
part of your question
was related to this could become a bigger problem in the future. Could you please talk a little bit more about what that means?
Sure. Yeah, I mean, I think an example would be that cholera had not occurred in Haiti for a very long period of time until the hurricane sort of in the early 2000s, when then there was epidemic cholera in Haiti. So I think, most travelers to the U.S. currently do not travel to cholera endemic areas, but Vibrio cholerae does have an aquatic reservoir, and so it can be hard to predict sort of what areas might become unsafe or cholera risk areas over time. And we also know that cholera is not just underreported in the United States, but likely also globally.
Thank you.
Dr. Bell?
Thank you. I had a question about safety. While I recognize there's not much safety data in the age group in question, the vaccine has been in use, at least certainly in adults, for some time now. And I wondered if you or someone else could comment on whether there have been any rare serious adverse events noted, and in general, what the reports to VAERS look like with use of this vaccine, just to give us a general sense of the safety experience once the vaccine has been used in the real world.
Sure. Chris, could you go to slide 68, please? Thank you. So we had our colleagues in the Immunization Safety Office pull data from VAERS. These are data from sort of when the vaccine was approved in 2016 up through February of last year. And to sort of orient you to the table, these data are generated using an FDA kind of empirical data Bayesian mining process. It's a hypothesis generating tool. But essentially, the higher the USEB05 number means it's sort of a stronger finding, and they often set the threshold for significance to be 2.0. And so what they're sort of comparing is how events are reported relative to other vaccines. So if the number is high, that means that this event was reported more commonly with Vaxchora than with other vaccines that have events reported in VAERS. And so you can see these are the only events that were identified that occur more commonly with Vaxchora than with other vaccines in VAERS. So the label drug-food interaction medication error relates to the fact that this is an oral vaccine that requires people to not eat around ingestion. People may have consumed food in closer proximity than was recommended. The product administered to patients of an inappropriate age may have been for patients. I believe that was for patients less than 18 years old, but it could theoretically also be for patients greater than 65 years of age. I think it's not quite clear what wrong technique and product usage process means, but it seems to be something related. The last two seem to be related to administration and not sort of serious adverse events that we'd be concerned about. So this does sort of underscore that it is sort of a complicated preparation and administration, and was a part of our discussion for why we would recommend it being administered in a travel clinic.
Thank you. Dr. Sanchez.
Thank you, and thank you, Jen, for clearly outlining all those aspects. I just want to voice more support for what you said. Clearly, our intent is that this vaccine is a travel clinic vaccine. So some of those inherent issues with administration can be facilitated. In terms, I think that the public health problem we debated a lot on because, although the cholera in the United States are few cases, there does seem to be a modest increase in the 90s in terms of imported cases. So, although ultimately it may not be a public health problem in the United States, in those individuals who are traveling to cholera endemic areas and who are, depending on the lifestyle that they have in those endemic areas, I do think it does then become a public health problem. But so I think we debated that a lot. And I think that it really is going to have to be, we do recommend it. I certainly recommend it in those individuals who are traveling to those endemic areas, depending on the lifestyle that they choose to have in those endemic areas. But I think it will. I would prefer to have a recommendation rather than just a shared decision making because of the adverse effects of cholera. So I think all of that was well delineated by you, and but I just wanted to just share some of my thoughts as well. And I think that it's anyway. Thank you.
Thank you, Dr. Sanchez. Dr. Lair?
Yes, I do a little bit of travel medicine, but I'm wondering what our travel medicine colleagues think about this. I was wondering if Dr. Elizabeth Barnett of the International Society for Travel Medicine is on the line and if her organization has any opinions. I'd be curious to hear what they say. Thank you.
Thank you, Dr. Lair. Dr. Barnett?
So thank you for that question. The members of ISTM would be happy to have this vaccine available to children who will be in a situation where they may be exposed to cholera in an outbreak situation or other situation where it could not be avoided otherwise. And I think it's not going to be used in a travel medicine situation for all traveling children, but travel medicine practitioners will be happy to have this vaccine available for the children who are eligible for it.
Thank you. Dr. Brooks.
Yes, two things. First, Dr. Sanchez mentioned the fact that we may have a low number of cholera cases in the U.S., but I would think that maybe much of the cholera that we may see with international travelers may happen in the area in which they travel to. And so I don't see that we have any documentation, any data on that. But my question is about how many doses per year for, I guess, those 18 and up of the vaccine are utilized right now?
Thank you for your point about many cases occurring internationally. I think that likely is true. It has a fairly short incubation period and can be a short illness despite the severity. I am not sure if we have numbers on how many doses have been administered. I can sort of look into whether it's possible to get those numbers and circle back with ACIP. So.
Yeah, thank you.
Dr. Grog?
Yeah, I too am a International Society of Travel Medicine person, and the question I would have about the recommendation at a travel medicine clinic, so many of them have closed because of COVID and the limited supply of yellow fever vaccine, and it may be difficult to find travel medicine clinics at the present time. I'm certainly in favor of the pediatric population as a pediatrician, and would recommend that the vaccine be available. But the recommendation about at a travel medicine clinic may be difficult, and I just wanted to throw that out. Thank you.
Thank you. And I'm going to jump in, Dr. Sanchez, and then give you the last word on this session. Just a couple, one comment and one question. I also think that in this context, a recommendation for those who are going to endemic areas makes a lot of sense. I actually feel like the shared clinical decision-making is when the benefit-risk balance to the individual is uncertain. In this case, I think what's uncertain is the risk based on where you travel and what we know or don't know about the prevalence of cholera in those areas. But if you go to a high-risk area, it does seem like a straight recommendation would be worthwhile given what was presented today about the benefit-risk balance. I do think additional clinical considerations or clinical guidance to help us understand what the actual risk is, either from the CDC team or from the International Travel Medicine, sorry, I apologize, I'm getting the organization name incorrect at this point, the International Society for Travel Medicine organization would be incredibly helpful to clinicians if a child, for whatever reason, is not able to get to a travel medicine clinic. So that's just one comment. One question I have for the team is what is the durability of the immunity? And if there is a long period of time between travel, when do you recommend revaccination? And would that be provided in the clinical guidance or in other areas?
Thanks, Dr. Lee. I'll say we are planning to do a clinical considerations presentation ahead of the vote at the next meeting, assuming the ACIP is amenable to the vote. As far as the repeat doses, there are no data about the safety or efficacy in preventing cholera with booster doses for the current formulation. And we don't know much about the duration of protection beyond sort of the 3-month period that was evaluated in that oral challenge study in adults aged 18 to 45 years. So for adults, ACIP does not currently have a recommendation regarding use of booster doses, and we will likely not make one for children either, given sort of the data vacuum. But welcome your input about that.
Thank you. I mean, if there's any opportunity to collect at least immunogenicity data in terms of long-term or long-term follow-up, that would be helpful if those data are available. Dr. Sanchez?
No, I just wanted to add again, in addition, I think that one of the things that we've learned is that endemic cholera in many of the developing countries actually don't get reported, and a lot of the cholera outbreaks that are occurring in endemic or cholera occurrences that are occurring in endemic countries are not being those countries are not reporting to World Health Organization. So we're really just seeing like the tip of the iceberg, because there's likely more occurring than there is more than we're going. So I think this vaccine will be an important contributor to the, to the travel medicine vaccine. Thank you.
Thank you. I don't see any additional hands raised, so what I would like to do is close this session. We ran into our break. I would like to give our team a 5-minute break, so we'll meet again at 15 minutes after the hour to resume our next session. Thank you.